Yeah, you were lucky to hit him on a weekend there. So he's very, I always tease him, tell him he's the smartest person I know. But he is, he's very knowledgeable. So that was, when I saw that in your discussion, I was like, yeah, you got to work with Kamal. So anyway, let's talk first about a little bit about the power injector. Um, Believe it or not, the power injector has not been around forever. When I first started doing CT, we did not have power injector. So all we had was a hand injection that we could do, or we would hang a bottle of contrast and kind of pressurize it and drip it in as fast as we could, which means that it took forever to get the contrast in, and we were really only able to scan in one terrible phase of imaging, which was pretty much the equilibrium phase, which is really no good for anything. But that's kind of how the way things used to be until scanners got to be really sophisticated and fast. And then we could no longer hand inject because there was no way we could get the contrast in fast enough. So we started using mechanical injectors. The mechanical injector has a lot of advantages. We can program how much contrast we want to go in. We can program how fast we want to inject it. They come single head and dual head. I don't know if anybody here is working someplace that has a single head. Most of them are dual head. I don't know, you guys can tell me, are most places using the dual syringes or only for certain exams? They're using, okay, so they're using, so probably at the advanced sites, they're a little cheaper. They're probably only using a saline chaser for certain exams, correct? How about Franklin? Does Franklin use saline chaser for every exam or
Just for CTAs.
just for CTAs? Mercy, just for CTAs?
It depends who's doing it. 'Cause
Oh,
David
okay.
doesn't use saline, but everyone else does.
Okay. And a saline chaser has advantages, so we're going to talk about that in a few minutes. But um, so anyway, you guys know that one syringe is for contrast and one syringe typically is for saline. You don't have to use both. You can just, use the injector as a single head and just load one, or if you need both, then you would load both. They all come with a programmable pressure limit, and we kind of touched on this last class. Did everybody get a chance to kind of look at that when they were clinical this week? Okay, the pressure.
Oh, yeah.
Pressure. So typically, I would say that the pressure, they probably set the pressure setting at 300 psi. Is that typical for most places? Okay, so they set it at 300 psi. And what you need to remember is that, like I told you guys, the angiocaths are pressure rated. So you want to make sure that when you're setting a pressure limit, that you're setting a pressure limit higher than what, am I saying this right? You want to make sure that you don't set it, that you need more pressure to inject. For example, if you have a 22 in, somebody talked about that, you have 22 in. A 22 gauge angiocath is going to take more pressure to push the contrast through than an 18 because it's smaller, right? So you want to make sure that you don't have a pressure setting that's not compatible with the needle that you have in. When you start the injector, you're going to see the pressure, and usually it's way below 300. If you have a good line in, that pressure is not going to go up at all. It's just going to be smooth sailing, and all the contrast is going to go in with no problem. If you start the injection and that pressure starts inching up, what do you think would cause that? Yeah, you start the injection, and all of a sudden the pressure starts going up. Like the pressure is the amount of force that's needed to push the contrast through. That's what the pressure is. Right, something's blocking it. Either maybe the patient moved their arm and the angiocath got kinked, or else the vein blew, and the mechanical injector is a machine. It doesn't know about veins or anything like that. It's just going to inject that contrast at the flow rate that you set it until it hits the upper range of the pressure setting that you put. So say you're injecting, everything's going fine, then all of a sudden it peaks up to 300 psi. The injector is immediately going to slow the flow rate down to try to bring the pressure down. That's a safety thing built into the power injectors. So it's going to inject at the speed that you asked it to, as long as that pressure is below what you have set. If it gets up to the pressure that you have set, it's going to decrease the flow rate to try to bring the pressure down. If the pressure does not come down, the injector will just cut off. So it's a safety mechanism. why do we have pressure settings? What's the reason, the whole reason for the pressure settings? The whole reason we want to set that. It's really, we set these to protect the integrity of the disposable components that we use with this, because if the pressure gets too high, the end of that catheter could like shear in someone's vein. So the pressure setting is really to really protect the equipment that we're using. It's not really to protect the vein, because it doesn't know it's a vein. It doesn't know, I mean, it might be able to detect an extravasation if some contrast starts leaking out around it, but it's really when it hits the upper pressure setting, it's going to try to fix itself, and if it can't, the injector is just going to cut off. So that's kind of why we have the pressure settings on there, so that we don't shear a catheter in someone's arm, then that would be really bad. So, like I said, some injectors will have safety precautions on there where it can detect if there's an extravasation. Some might be able to detect if there's air in the line. So it kind of all depends on the manufacturer of the injector. Does everybody understand that about the pressure settings? And you want to make sure that the equipment that you're using is compatible with the pressure that you set, okay? So loading the injector. So loading the injector is an art. You need to make sure that you do it properly. What's one of the risks involved with human error when we're loading these injectors? Priming the line, flushing it out, making sure there's no air in there. Yeah, we want to make sure that we get all the air out, because we definitely do not want to inject the patient with air. A little bit of air is probably not going to hurt somebody if it's a few cc's. A syringe full of air will kill somebody. So, and you guys have seen those syringes, everything's clear, that you can't even tell that there's contrast in there. So you just want to make sure that you're very careful when you're loading those syringes, that you turn that knob, prime it, run the contrast all the way out to make sure that you get all of the air out. When you're setting this up, how should you set your injector up? Should you tilt it vertical, horizontal? How? How should you do this? This way?
To put it in, tilt it towards you?
When you're setting this up and they're getting ready to inject somebody, how is the injector set? They put the syringes on, do they tilt it?
Yeah, it's upside down and it's right in front of the gantry.
Totally upside down, like totally vertical?
Like
it's
a
a little bit
slant
of angle.
Is that a slant?
Well, how much of a slant? Because this is important, because we want to try to get all the air to come to the rear of the syringe. So the angle of this is extremely important when you're injecting somebody.
There's deep angle. It's almost vertical.
Honestly, have never seen them angle it. Like I see them go pop. The
It's
syringes
like-
pop. It's like we fill
They
it,
just
we prime it, and then we flip it.
Okay, so this is a Mallinckrodt. Who uses a Mallinckrodt? Advance uses a Mallinckrodt. Who uses a Medrad? Okay, I'm more talking, I mean, the same things go for Medrad and Mallinckrodt, but Mallinckrodt has this, and when you're loading the injector, I want you to pay attention to this. Okay, so you load the injector up, you're ready to go, getting ready to tilt this. You're going to tilt this about 30 degrees. Okay? Watch these. That's how much you should tilt it. The Mallinckrodt will flash, and then you know you're at the correct tilt.
It's never like that.
No, it's not. No.
It's not. Keep, tilting it some more.
Probably a little more.
This is the safest way to inject somebody. This at 30 degrees brings all the air to the back of the
So
syringe.
this is how it should be
This is how it should
positioned
be.
when we connect the
Correct.
line to.
Your injector should be like this,
Oh.
30 degrees. Not like this, not like this. Yep, and this has that, I don't know if Medrad has something like that.
But they do like around 45, kind of looks like 45, kind of like this.
Okay, so it's not completely vertical. Okay, so,
I don't know, but honestly, I don't think I really pay attention to
to like when she's setting things up, it's like that. But when she's getting ready to inject, she kind of like tilts it down a little bit because she reaches over to fill the vein when she's injecting. That's the only time. She's on wheels, but she like it does.
Ours
It's
is
like,
in the ceiling.
she can turn
She
that
has
way.
an arm. Yeah. So anyway, you all know the correct way to do it. Now, I'm not saying go back, but maybe
Yeah,
tell
yeah.
them, say, hey, did you know that when you tilt this down and it's at 30 degrees, these are gonna flash and tell you when to stop tilting it? So yeah, this is the correct way, this is the safest way, this is the way it's supposed to be done, per the manufacturer of this injector. So 30-degree tilt. Degree tilt. Let me make sure it's flashing both time. Any residual air will go to the back of the syringe. We do a patency check, so we want to make sure that we flush, run that contrast all the way through to get all the air out. Okay, suppose you are injecting somebody and you realize you've just injected somebody with air. How do we treat that person? This is important because you never know when this might come up. What position are we putting them in? Immediately, we have to put the patient in this position. Nope. Nope. It's a decube, left or right.
Right.
50-50.
Left or right. Okay, so let me give you a hint. We want the air to stay in the right atrium. We don't want it going we want to stay in the right side of the heart because we don't want it going out to the rest of the body. We don't want to kill the person, so we're going to put them in left lateral decubitus immediately, and then we put them on 100% oxygen. That's how you treat somebody if you realize that they've been injected with air. Let's pray that that never happens. Okay, so just make sure you guys are, that's one of the reasons that you guys are not allowed to really touch the injectors at the outpatient center is because somebody was injected with air someplace, and who do you think they blamed? The student, right. So it's really a safety thing for you guys, but if you can't load the injector, just please be in there like watching. Watch everything she does. Watch when she purges it. Watch when she tilts it. Watch, just learn as much as you can. And then hopefully when I get you guys to a hospital, you'll get some hands-on. I think St. Joe lets you do it. Probably Franklin lets you. Mercy lets you. Good Sam. So yeah, so we'll get you some experience. But just get as much of experience with that as you guys can, because when you go to the outpatient center, you're not going to get to touch the injector probably. Okay, so we want to make sure, because most errors with the injector are human errors. It's typically not a malfunction of the injector. It's usually human error that causes the issues. Oh, that's just him tilting the injector. Okay, so let's talk about that saline flush. So some of the advantages of using a saline chaser are sometimes it can help to reduce wasted contrast. Have you guys ever noticed that after you inject somebody, if you don't use a saline chaser, there's this dead space right here. Contrast is just sitting in there because the injectors run, it's run through, and this is left in the tubing. This is about 15 cc's. So if you're thinking you're giving your patient 100, and then there's 15 cc's left in the dead space, you're really only giving them 85, right? But if you use a saline chaser, they're getting the whole bolus. They're getting the whole 100 because you're pushing all that wasted contrast through. So it reduces waste by pushing all that contrast through the peripheral veins and through the tubing. It may permit you to reduce the dose of contrast that you use. It also helps to reduce artifacts. Did you guys ever notice when you're scanning somebody, especially for a chest, you get this real bright area right here in the superior vena cava? It's just, the contrast has just come in, it hasn't mixed with anything, it's so bright, and you get all these beam hardening artifacts. Well, a saline chaser will help to alleviate those artifacts. It will also help. Saline will also help push the contrast forward and get it to the targeted area quicker and at a higher concentration. So they say it tightens the bolus. That's what they mean when they say it tightens the bolus. It means it gets it to where it's going quicker at a higher concentration. So there is a lot of advantages of using saline. It could save you money on one end because you may be able to lower the amount of contrast that you use. But on the other end, those syringes are expensive. So if you're drawing saline contrast up for every patient, you're using 2 syringes. Those packets of syringes are expensive. So that's probably why Advance stopped doing it for every patient. They only do it for certain studies, like CTA studies and things like that. Yeah, so that's just showing the artifact. Okay, so which do you think is more important? The timing of the scan or the delay, the speed at which we inject it, or both? Everybody say both? You are correct. Let's talk about scan delays first. So when we say the word delay, we're referring to how long we're going to wait between the time that the contrast injection starts and the time that we start the scan. Everybody understands that, correct? Okay, so timing is the challenge of CT. We get one shot at this, especially if we're doing a study where we only want to see the artery, we want to do a CTA maybe of the carotids, or we want to do a CTA to look at the pulmonary arteries. If we screw the timing up, we could screw the whole scan up. So that's why, when we're doing like brains and stuff, that's why new techs get real nervous when they do a CTA, because they're, you get one shot at it. And you want to make sure that you get it correct. And luckily for us, and we're going to talk about that a little later in this PowerPoint, we don't have to like guess at timing anymore. We have all this software now. We have bolus tracking and smart prep, and I don't know what other manufacturers call it, but we don't have to guess anymore. We should be able to precisely time things now with this kind of sophisticated software that the scanners have now. So some typical contrast arrival times. And this is just in case you didn't have any of that software on your scanner. If you want to look at the carotids, somewhere between 16 and 24 seconds. If you want to look at the, let's see, what else is here? Femoral arteries, renal arteries. These are just some typical contrast arrival times. Typically, a routine abdomen done in the portal venous phase is about 60 to 70 seconds. I would think that that was across the board what people are using. Usually a routine chest is about a 30-second delay. I would think that's pretty routine across the board for everybody, around 30 for a routine chest. So what's going to affect the timing? And a lot of things are going to affect the timing on patients. Not every patient's delay is going to be the same because everybody's a little bit different, depending on your age, depending on your size, mostly depending on your cardiovascular status, like how fast your heart is pumping is going to really be a factor in determining what delay that you're going to use. So just to kind of go through what happens when we start the contrast, we're in the antecubital, then it goes through the subclavian, into the brachiocephalic vein, into the superior vena cava, then into the right atrium, and then it goes into the pulmonary artery, and then to the lungs, and then it comes back through the pulmonary veins, into the left atrium, into the aorta, and then out to the rest of the body. So that sounds like it's a lot, but if your heart is, if you're young and you have a strong heart, it's going to be quick. But not everybody's is going to be quick, just depending on their health, cardiovascular status, things like that. Okay, so this is the part where I start getting like the deer in the headlight look. So let's talk a little bit about phases of tissue enhancement. So predominantly in CT, we talk about 3 phases. We talk about the bolus or the arterial phase. We talk about the portal venous phase, or some people call it the non-equilibrium phase, and then there's that delayed phase or the equilibrium phase. Have you guys all heard these terms being used at clinical? Okay. The difference amongst these phases is going to be predominantly determined by the rate at which we inject the contrast and the time that elapses from the start of the injection to when the scan is initiated. And I'm going to post this PowerPoint for you guys, so you don't have to try to write everything down. Okay, so before we talk about those phases, let's just review Hounsfield units. Have you guys all had a chance to see them on the scanner? Does everybody understand what those units represent? It's like a density number. It's going to define the characteristics of the tissue contained within each pixel. So basically you have negative 1,000 to positive 1,000. And right in the middle you have water, which is 0. So that's why every morning a water phantom is done to make sure that that equals 0, because if it doesn't, that's going to screw up every diagnosis you make because your Hounsfield units are off. So every morning a water phantom is run to make sure that it comes out at 0. Bone is going to be 1,000. Air is going to be minus 1,000. So plus 1,000, minus 1,000 at two different ends of the spectrum, with 0 water being right in the middle. And then I just gave you over here some typical Hounsfield units. Like the liver is going to be somewhere between 40 and 60 Hounsfield. Blood is going to be around 40. Water is 0, so that cysts are water. So cysts are also going to measure 10, 15, maybe 20. If you measure a kidney cyst and it's more than that, then it's probably not fluid filled. It maybe has pus in it or something. So things that are closer to water are probably cystic, and things that are higher are probably solid or have pus in it or something like that. It's not clear water. Air is always negative 1,000. Air always shows up what on CT? Black, right? Fat is going to be negative number 2, negative 50 to negative 100. So you're going to use these every day. You're going to hear Hounsfield units. You guys are going to get used to using them, and we're going to talk about them tonight. Randy's going to talk about them when she teaches you, and Kamal's going to talk about them again when he teaches you. So we're going to talk a lot about Hounsfield units because they are very important in CT. Okay, so CT Hounsfield units, let's just talk about an abdominal CT in the arterial phase. So this is that real early phase, about 15, 20 seconds after you've injected the contrast. So the aorta with contrast is going to be about 200 to 500 Hounsfield units. So it's very bright. It's got a lot of contrast in there. It's a high concentration, and you can't really see anything in the veins. Then this is the portal venous phase. This is the phase that we typically scan in. This is about 60 to 70 seconds after the contrast has been injected. And you can see now the aorta is not quite as bright, but it still has contrast in it. It's going to be around 100 Hounsfield units. Okay, so some terms that I want you guys to be familiar with, because I'm going to be using them when I talk about these phases of tissue enhancement. When we say something is hyperdense, what does that mean to you? Hyperdense, like really white, right? Really white, really bright. Hypodense is going to be less dense than the structures around it. So it's going to be like more grayish. And then isodense is going to be the same density as everything around it. So hyper, real white. Hypo, not quite as bright. And then iso, everything looks the same. Now, before we talk about the phases of tissue enhancement, majority of the time we're going to be talking about the liver, because we scan the abdomen a lot, talk about the liver a lot, we scan the liver a lot, and you guys that I taught sectional anatomy to should know the answer to this question. So the liver is like a kind of a really unique organ. It's supplied by blood by two sources. Who knows what those are? Good. Hepatic what? Artery, right? And portal vein. Yay, y'all remembered something. Okay, so like I said, your liver's a very unique organ. I don't know if you guys knew this or not. You probably did. But anything you put in your mouth goes through your liver before it goes out to the rest of the body. And your liver kind of decides what it does with stuff that you digest. That's why when people are having a heart attack and they need nitroglycerin, they don't swallow it. They put it under their tongue, and then it gets absorbed because you want it at the highest concentration to get to the heart. So the best way to do that is to have it be absorbed, not digested, because then it breaks down, and then it wouldn't get to where it needs to go at maximum, the maximum potential that a drug could get there. So that's, so the liver is a very important organ, and we scan it a lot. And you guys probably know that by now by being in clinical. So anyway, hepatic artery supplies the liver with blood, supplies the blood 20% of the blood supply, hepatic artery. Portal vein, 80%. So when we're looking in this early arterial phase, anything that's enhancing is being fed by the hepatic artery, okay? So when we talk about the arterial phase, like I said, this is the phase that immediately follows the bolus injection. It's about 15, maybe 20 seconds after we've started the contrast. In this phase, all the arterial structures should be enhanced. So you see the aorta here is nice and bright, and then we don't see any veins yet. All we see in this phase is arteries. We know we have a good arterial phase if we put a ROI on the aorta and the IVC, and there's a difference of 30 or more, then we know we got a good arterial phase. Does that make sense, everybody? Okay. So the next phase would be the portal venous phase, and this is the phase that we routinely scan an abdomen in. A routine abdomen gets scanned in the portal venous phase. The portal venous phase is going to begin about a minute after we start the injections. Most places do 60, some places may do 70 seconds, just I guess it depends on your scanner. So you're going to notice in the portal venous phase that, of course, the aorta is still bright, but not quite as bright, but we have contrast in the veins now. So the difference between the aorta and the IVC is now between 10 and 30. And you can also see, too, what's happened to the liver. When we look at the liver in this phase, see how, like, gray it is? And then we look at it in the portal venous phase, the parenchyma of the liver has started soaking up the contrast now. The last phase of tissue enhancement is the equilibrium phase or the delayed phase, which is probably the worst phase you can scan in. You're probably better off scanning a dry abdomen than trying to diagnose anything in the liver in this phase. The only thing this phase is good for is to look at the kidneys in a delayed phase so you can see the excretory system. Or if you're scanning the liver and you want to see if something's a hemangioma or not. Has anybody heard of that term, hemangioma? So the difference between the aorta and the IVC in this phase is less than 10 Hounsfield units. All the contrast is emptied from the arteries. It's all diluted in the veins, and the liver parenchyma has just soaked up everything. So if there was any lesions in this liver, we would never be able to see them now. That's just, we're at like equilibrium now. We're at like that isodense, everything looks the same now. So looking at all three phases, here's your arterial phase. Like I said, the liver is real gray. So what shows up nice on here is these hyperdense lesions are going to show up real nice on the arterial phase. Then you have the portal venous phase where the liver is real bright, so those hypodense lesions are going to show up. There's not one on here, but I'm going to show you one. And then here's the equilibrium phase. So see how this big mass right here, we can barely make it out on this phase, and then we can't see it at all in the equilibrium phase. So had this patient not been scanned in the arterial phase, we would have missed this. Okay, so here's the question. Since it's so wonderful, does every patient need to be scanned in all three phases? What's the answer? No. Depends on what they're looking for. What would be a reason to scan a patient in all three phases? Because not every patient needs it. We'd be radiating everybody to death if we scanned every single abdomen we did in arterial and venous phases. So every patient does not need multi-phase imaging. We're going to use arterial phase imaging in the following situations. So this is what we're going to do. If we want to characterize a liver lesion of unknown origin, so say a patient goes and has an ultrasound for abdominal pain and something shows up in their liver on the ultrasound, then they send them to CT. We don't know what it is, so that patient needs multi-phase imaging. When we're trying to rule out hepatocellular carcinoma, so all primary liver tumors are fed by the hepatic artery. Hepatocellular carcinoma is a primary liver cancer. There's metastatic liver masses. That doesn't mean you have liver cancer. That means it's metastasized from another cancer to your liver. But hepatocellular carcinoma is a primary liver cancer, and those tumors are fed 100% by the hepatic artery. So if we don't scan in the early arterial phase, we're going to miss those. Patients that have cirrhosis. If we're trying to detect METs in patients with hypervascular tumors, and what that means is there's some cancers that produce hypervascular METs. There's some cancers that just produce hypovascular, like colon and a couple other cancers, but some cancers produce or are fed by the hepatic artery. So we need to make sure that we know which cancers they are so that we know if they need multi-phase imaging or not. Most hypervascular lesions are going to be benign, but there are some, like a primary liver cancer and some hypervascular METs, that are not benign, so we need to make sure that we know the difference between those. So benign things, hypervascular lesions, are going to be focal nodular hyperplasia, and adenoma or hemangioma. They're all benign things that are hypervascular. Malignant things that produce hypervascular lesions are primary liver cancer, HCC, hypervascular METs, which come from breast cancers, sarcomas, neuroendocrine cancers, renal cell cancers, and melanoma. Those are the cancers that produce those hypervascular METs. Am I getting the deer in the headlight look yet? Okay. Okay, so let's look at a couple hypervascular lesions. Most, like I said, most hypervascular tumors are going to be benign, but you have to differentiate them by looking at the enhancement pattern in other phases. So here's a good arterial phase. We see that the aorta is nice and bright, the liver's gray, no, it hasn't soaked up any contrast yet, and we can see these hypervascular lesions right here. Same patient in the portal venous phase, can't see them. So that's why it's important in certain patients that we do both phases of imaging. Okay. Hypovascular lesions. Most hypovascular lesions are bad. Most of them are cancerous. Hypovascular liver tumors are more common. Most METs produce a hypovascular. This is when the portal venous phase, when the liver is a little bit brighter, and then you can see these kind of hypodense lesions. Everybody with me? Okay. Just another patient to show you how terrible the equilibrium phase is. Image A was taken in the portal venous phase, and there was a conspicuous hepatic abnormality. Image B, same location, 2 minutes later, can't even see anything. See all these? You can't even see them here. A hemangioma, I was just talking about that a couple slides ago. A hemangioma is a benign liver tumor. When you see a hemangioma, or maybe we think it's a hemangioma, it will start to fill in with contrast, and the contrast will stay filled in there. Most hypervascular tumors contrast comes in, contrast goes out. But a hemangioma, the contrast, we do like delayed imaging for these. You might do 2 minutes and you might wait 5 minutes. And if the whole lesion fills in with contrast, we can definitively say that's a benign mass. It's a hemangioma. So you may run across those, while you're clinical or when you start your career. If you see something like this in the liver, you have to do delays. You got to do delays on this. Now, multi-phase imaging isn't just for the liver. We'll multi-phase image in the pancreas, and we'll multi-phase image in the kidneys as well. If you're trying to stage somebody for pancreatic cancer, they should be scanned in 3 phases, an arterial phase, a pancreatic phase, and a portal venous phase. And when Randy teaches you guys scanning procedures, she's going to go over this way more than I'm going over it. But I just wanted you guys to know that it's just not only the liver that we multi-phase scan. We multi-phase pancreas, we might multi-phase kidney. You guys have probably done this, where you've seen this, where you do like maybe a dry, and then a arterial, and then a venous, and then a delayed for kidneys, because you want to differentiate kind of the cortex from the medulla here, and then you want to be able to see this excretory phase. So we do multi-phase scan kidneys as well. Okay. Everybody with me with multi-phase imaging? Have you seen some of this at clinical? Okay. Have you noticed that they only do it on certain patients? Not everybody gets multi-phase imaging? Okay. All right, so let's talk a little bit about flow rates. Flow rates, the flow rate is how fast we're going to inject the contrast. For arterial phase imaging, the best results are with an injection rate of anywhere from 3 to 5 mLs per second. So we have to get the contrast in there fairly quickly. There's 2 reasons for this. You get better enhancement at 5 mLs. There's going to be more contrast delivered when you start the scan. So, okay, so let's think about this. So you're scanning an abdomen, or you're scanning a patient for maybe not an abdomen. Maybe we're rolling out PE. So we're rolling out a PE. We're going to scan the patient. We're going to use a 20-second delay. We're going to scan the patient at 5 cc's per second. So when we start scanning, how much contrast is in there? So we're injecting 5 cc's per second. We're starting the scan at 20 seconds. This is easy math, guys. How much contrast is in there when we start the scan? How much contrast is in there? 100, right. So say we're
20 times 5.
So say we're going to be nice, and we're going to because we don't want to inject too fast. So we're going to inject it. We're going to inject it 2 cc's per second. So we're injecting it 2 cc's per second, and we're starting the scan at 20 seconds. So how much contrast do we have in there? 40. 40 cc's of contrast. That's terrible. That's terrible study. That's not enough contrast in there to get a good study. So do you see why it's important? We have to get contrast in fast. These delays are short, so we want to get as much in as we can before we start the scan. So we want to be nice to our patients, but we want to give them a diagnostic scan. So we want to make sure we're scanning at the correct flow rate for the delay, for whatever scan that we're using. So better enhancement, there's going to be more contrast there when we go to scan, and the contrast is also going to arrive there quicker at a higher concentration. Everybody understand? Makes sense? Okay. Okay, so this is a patient, real patient. Patient was injected because we wanted to be nice, and they didn't want to inject it too fast. We only injected them at 2.5 mLs per second. Patient had to come back for a repeat scan because maybe there's something here, maybe there's not. Patient comes back, 5 mLs per second. No question now that patient has a pretty large hypervascular mass in their liver, probably a primary liver CA. Again, 2.5 cc's per second. Maybe there's something here. Patient comes back, 5 mLs per second. Much better scan, better quality scan. Patients that have like pancreatic cancer or primary liver cancers, usually by the time that they're diagnosed, it's kind of in a late stage. And usually what happens is if they go back and look at scans that the patient had prior, it was there. That's why you just missed it. Was it? I don't want it to be my fault that it was missed, you know what I mean? Like, so we want to give the patients, and not that every patient can be cured, but the earlier that we can find these, maybe these liver cancers can be resected, things like that. But, you know, the radiologist is only seeing this. He's not going to look and see how fast you injected the contrast. He's trusting that you're following the protocols that he set with a whole group of people, that you're injecting it correctly, so he can definitively say there's nothing here. But if we're not doing the scans the way we're supposed to be doing them, we don't want something to be missed that's our fault. So if a patient has a bad line and they're not going to be able to be injected as fast as we need them injected, then they need to get a new line put in. They need to get a new line put in, or else we're doing them a disservice. So has anybody seen these Diffusix needles, angiocaths? Because not every patient is going to be a candidate for 18 or 20 gauge needle in their arm. It's not going to happen, especially patients that have really poor veins. But these Diffusix, instead of the contrast coming just out the front of the needle, it has all these ports. So the contrast doesn't come straight out, it comes out all these ports. So you can put a 22 in and still inject like 5 mLs per second without running the risk of.
They have them, they just don't use them.
Do they use them? They don't use them for anybody?
I haven't seen them.
They're
I've
expensive.
seen them, but they're like, well, we don't, they're, I don't know, I guess they just don't really like them, or it's confusing, I don't know. So they
Don't
usually
tell
just
me,
use-
don't tell me this. Yeah, so these Diffusix are great for a patient that has bad veins, but you have to do a CTA, you have to do a study where you're injecting them 3, 4, 5 mLs per second. If you can't get an 18 or a 20 in, but you can get a 22 in, you can choose a 22 Diffusix and still inject them at the normal flow rate. They're not cheap, so Advanced is cheap, so they're probably like hoarding them, you know, but that's what they're used for. So
Now, would it also depend on how, I guess, they feel? Because the techs have said that they feel like they're, sometimes when they put the needle in, they feel like the vein's small, so they will lessen the amount of the flow rate. Because they don't want it to, I guess, flow the vein.
right, is that giving the patient a good study?
Well, I would think not.
Right.
But then, in that situation, would you look for a different vein, or they just end up going down to their wrist, or their hands?
Yeah, I mean, I guess it would all depend on the situation.
Yeah.
You know, if I'm doing a routine abdomen and I don't need to inject that fast, then maybe I'll knock the flow rate down a little bit. But if you're doing a study for something, especially if you're multi-phase scanning, I mean, we have to get the contrast in fast. And we want to make sure we get enough in before we start the scan. Like I said, 40 cc's of contrast is not enough to diagnose a PE. It's just not enough contrast in there. All liver lesions are going to be best. Diagnosing a liver lesion or seeing a liver lesion is going to be determined by the amount of iodine that we get in there. We need a decent amount of iodine. All contrast has iodine in it. You guys know this. All contrast has iodine in it. Iodine is what, it has a high atomic number, so it attenuates the beam. So that's what makes the structures real white. So we need to get a decent amount of milligrams of iodine in there in order for us to see anything. So if we're only putting 40 or 50 cc's in before we scan a liver, it's not enough iodine in there to really enhance the tissue like it should be enhanced. So anyway, I'll get off my soapbox and we'll move on. Let's talk about iodine concentrations. And you guys have told me today there's a variety of concentrations that are being used. I think Kelly said for a routine abdomen they use 300 concentration. You guys were doing something, you used 350 because the stock was low or something like that. What are they using at Mercy? 350? Okay, that's a pretty high concentration for routine study. I would think a routine study, 300, 325, 350 maybe for CTA. How about Franklin? Routinely using?
Only Everson that use 300.
Only 300 for everything. CTA, every study. Okay. So, iodine concentration is going to be determined by the number of iodine molecules that's in it. The iodine concentration of an individual contrast agent determines how radiopaque the agent's going to be. Like I said, iodine has a high atomic number. It attenuates the beam, which makes the structures, real white when we see them on CT. So why not scan everybody at a high concentration? If it makes the scan better, why don't we do that? Well, you don't get something for nothing. So the higher concentration, there's things that we have to think about. There's increased viscosity. What's viscosity? The thickness, right. So there's increased viscosity with a higher concentration of contrast. There's increased, that word, osmolality. What does that mean?
Number of particles in solution.
Yes, number of particles in solution. So we want things to be very low osmolality. We want things to almost be the same osmolality as our own blood. We don't want to mess up a patient's homeostasis. When we inject in the body, anything that's as close to our own blood, patients are going to have less side effects from it. When you inject and there's a higher osmolality, the patient's body goes, whoa, what's happening? And it tries to immediately get itself back into homeostasis by shifting water around. And usually you and me and healthy people, we can do that quickly. It's no problem. We don't even feel it. We go through that fluid shift and everything's fine. But people that are not healthy or have maybe congestive heart failure, that shift in water in there to try to get things back to equilibrium is what causes patients to have problems when we inject them. So the lower the osmolality of a contrast agent that we use, the less chance the patient's going to have a reaction to it. So there's a greater risk of adverse reaction. So yes, it's more iodine. It makes the scan probably a little bit brighter and more diagnostic, but then again, like I said, we're not getting something for nothing. The risk goes up a little bit using a higher concentration of contrast. So the higher concentration should be saved for studies that need higher concentration, like CTA, rule out PE, looking at carotids, circle of Willis, things like that. Routine abdomen, probably 300 concentration is perfectly fine. So I just put this in here to show you guys that suppose we can't inject a patient 4 mLs per second. In order to get the same amount of grams of iodine in, we could use a higher concentration but lower the flow rate. So a 400 concentration at 3 mLs per second is going to give you 1,200 milligrams of iodine. And a 300 concentration at 4 mLs per second is going to give you the same thing. So that's one way you can, if a patient has bad veins and you need to do a good study, but you can't inject it as fast as you want, you could maybe use a higher concentration of contrast. Does that make sense? So I just put this chart up to kind of show you the osmolality of some contrast agents, things that you guys are probably using. Omnipaque is probably something that you guys are using. Hypaque. Is anybody using or used Visipaque? Does Franklin have Visipaque? Or they're hiding it, like probably Advance probably has it. Yeah. Visipaque is, if you can look at the osmolality here, 290. So Visipaque is a contrast agent that came onto the market in the early 90s. It has an osmolality equal to that of blood. So it's, the patients don't have that, they don't get that warm feeling, you don't have that shift in fluid because the osmolality is so low. It does have some advantages of using it, particularly in patients that have renal complications. It eliminates all those minor problems associated with contrast, such as that warm feeling. But different institutions are going to have different rules about who gets it because of the low osmolality. What do you think it is? Very expensive. It's very expensive. In the literature, it's been shown that you can inject a patient up to 3.0 creatinine with no problems. So it's safe for patients that have some kidney issues. It's useful in patients who've had prior reactions. But one thing to note is there's also been an increase in delayed reactions with VisiPig. So patients that have had VisiPig go home and then they call, hey, I got a couple hives. So it's one thing that has come out of some of the literature is that it has been associated with delayed reactions. So when would we use this VisiPig, or it's called isoosmolar contrast? I guess different vendors call it different things, but this vendor calls it VisiPig. We would use this with any coronary angiography study because it's going to create no issues like patients that get that warm feeling, then their heart starts racing a little bit. Like when you're doing angiography studies, you want the heart rate to be as low as you can get it. So it eliminates all that. So it's good for PE studies. It's good for patients that have elevated creatinine, patients that have any kind of kidney issues. It's good for diabetics because it's easy on the kidneys. Any study where the coronary function's involved, it has the least impact on cardiac function. So it is a good contrast agent. Will we one day go to 100% everybody gets VisiPig? Maybe. I never thought, when I first started, we still had ionic contrast. So every patient, we would take a history just like I had you guys do, and then we would take the sheet back to the radiologist and he would say, ionic, non-ionic. He divvied out who got what because ionic was, was new on the market and it was very expensive, so every patient wasn't getting it. But then as time went on, they went to 100% everybody gets non-ionic contrast. So will that happen with isoosmolar? I don't know. I think non-ionic contrast is pretty safe. How many of you guys have been involved so far with a reaction? Minor? Was it minor reaction?
Yeah,
Hives? No problem breathing or anything? How about yours?
She was throwing up, but
Sometimes that can just be a side effect from the contrast. It can turn into something more, so I would definitely watch a patient that starts vomiting or sneezes. Anybody had that one patient that like, achoo! You're like, your ears go up. Yeah, that could be the start of something. Somebody sneezes, somebody coughs. I would definitely be on high alert. And I know some of you guys in the original discussion, the thing that made you most nervous was contrast. Several people put that. And as it should. I mean, every time you inject somebody, you should be a little anxious. Because when you lose that anxiousness and you get real complacent, that's when something's going to happen. So you want to make sure that you always take a good history. Any red flags, you take them to the radiologist's attention. You ask him his opinion. And then he knows that you have somebody on the table that you're worried about. So it kind of alerts everybody to, be on standby. And then as soon as you inject that patient, you go right in and check on them. Let them put their arms down, get a good look at them, make sure how are you feeling? Are you feeling okay? If you need me for anything, I can see you. I'm just going to check your images. If you need me for anything, just raise your hand or yell my name. I'll come right in. But don't become one of them techs that injects the patient from behind the control panel, talks to the patient from behind the control, and never goes in until the study's done. Don't be that person.
They always go in.
Yeah, they always go in as soon as the injection's done. Everybody's doing that at every place.
we turned somebody away because they didn't remember if they had any they don't remember if it was MRI or CT contrast, but they were 75-80% sure that it was CT contrast, and it was 25 years ago, and he's like, I had hives and itchy throat and a little shortness of breath, and she went to the radiologist, and the radiologist was like, whoa, this could be more severe this time, his throat could close this time and not be itchy, it could actually close. He's like, no, turn away. He's like, just give him the steroid pack that they give out, and he's like, you're gonna have to come back on a different day.
Yeah.
And the radiologist will have to be in the CT room when he's injected.
Wow.
So I don't know when he rescheduled, but he said he was gonna come back to us, but I don't know when he was.
Well, good. Well, good for them. It's better to be safe than sorry. And if it's a reaction that has anything to do with breathing, it might even be better to have them done in a hospital setting or something.
That's what they said. They're like, it's more safe on our part and on your part that you do this with the steroid pack and not us just say, okay, we're going to do it right now because it could be a lot worse right now.
Right.
He's like, I totally understand. He's like, I don't want to die on this table. And they're like,
Yeah,
"No,
no, we don't want you to either. One of my students that graduated in December called me the other day, and she was hysterical on the phone. like I couldn't even understand what she was saying. And she was telling me that she had just had a bad reaction. And she's like, I had a really bad reaction. The patient, and she was telling me, and she was freaking out, and she was so nervous for the rest of the. Like, she's like, I don't want to inject anybody else, and I'm like, you've been initiated now. The patient was. They sent the patient 911 to the hospital. Radiologist came in. They did, they did the whole 9 yards. Vitals, and I think they gave him epinephrine, and it was a pretty bad reaction, but yeah. Oh, you were there that day?
I was an X-ray.
But, you know what? Reactions are rare, but they do happen. And even a patient that tells you that they've had contrast multiple times, it just could be that, that day that something just doesn't feel right with the patient. And you just have to always be on standby. You know what I mean? You just never want to get too complacent. You should always have a little anxiety when you inject somebody. Yeah, I've had some bad ones over the years. Early in my career, I had somebody like immediately, it almost looked like they just got a sunburn right away, just like red, just. Did I tell you guys about my friend Kim who had a bad reaction, and her patient was just laying like this, and they were dead. Mm-hmm. Yep. She injected them. She got right up and went in to see if they were okay, and they just were unconscious. They never even moved, arms overhead. So she called a code, and they came in, and they worked on him and did everything they did, but he died. So I don't know if he just, yeah, it was. But luckily she got, what if she would have said, oh, he's fine, da, 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 da. Like she would have had to live with that. But she said, I went right in, and she called a code right away, and yeah, she did everything right. It just, you just never know. So I don't want to scare you guys about injecting people, but I just, it just drives me nuts when people get very complacent and, a little bit lazy, and they, they don't get up and they don't check on people, and want to make sure that you don't start with good habits. Okay, so how about the answer to this question? I think we touched on this a little bit. Can we use less IV contrast with these faster scanners? Can we use less IV contrast with faster scanners? Yes, no, maybe. That's exactly the answer. Yes, no, and maybe. With faster scanners, it's easier for us to target the timing. So we could drop contrast volumes on small areas, maybe if we're doing a small targeted area, like looking at the adrenals, or we're looking at, what else would be a small targeted area? Something small, like, I don't know, renal artery or something like that. Something specific that we're looking at, and we can target the timing, and we could probably get away with using a little bit less contrast. For cardiac studies, most facilities are going to use around 80 cc's. That should be like the minimum that you should use on a cardiac study. For routine abdomens, you're going to see a variety. People are going to use maybe 120 to 150, but most facilities are at about 100 cc's for an abdominal CT. Using a saline chaser is also going to help you make more efficient use of your contrast. You can drop even lower, but you want to be careful because certain areas like the liver, like I said, your ability to detect your liver lesions is going to be very much based on the number of grams of iodine you inject. So you want to be careful that you don't dilute the study too much and miss lesions. So in cases with patients with borderline renal function, sometimes we can decrease the contrast a little bit to help out their kidneys a little bit. If you're scanning, like I said, more limited areas, it's easier to get away with less contrast. So the best studies and the safest study and the most efficient study is going to be the study that's done right the first time. So even if you're trying to skimp on contrast, you're like, oh, it's an abdominal and it's looking at the liver, and maybe I'll use 75 instead of 100, and then your scan stinks and the patient has to come back, and then you're going to scan them again with another 100 cc's of contrast. So the best thing to do and the safest thing to do is just do the scan right the first time. We don't want to skimp, especially when we're talking about the liver.
Well, can they reuse the contrast if they don't use it all?
What do you mean?
Because if you're trying to skip on
No, I mean, some places don't
Oh,
do that. Some places will draw up out of like a giant, you know,
okay.
and they'll only draw up 75 cc's. They won't draw up the whole 100.
Oh.
No, but no, you couldn't reuse that. No. Okay, so let's talk about automatic injection triggering. So you guys have seen this. This is the software that they have on the scanners that helps us to pinpoint our timing. We don't have to guess anymore. There's two methods that exist for this that I know of. There's test bolus, where we give the patient contrast, and then we figure out the timing, and then we set the time that we've determined is the best at peak enhancement. Or there's bolus tracking, where we're actually using the contrast itself to initiate the scan. I don't know. Have you guys used both? Most places use bolus tracking, I would think. But the test bolus, you're going to take 10 to 20 mLs of contrast, and you're going to inject it, and you're going to do several you're going to do several trial scans, and then you're going to look at all those scans and see which one has the best enhancement, and then you're going to figure out the timing by using like a little grid like this, like, you know, this is like maybe 100 or 200 Hounsfield units, and this is maybe, I don't know what this says, 0, 10, 20. So this is probably like 15. So maybe at 15 seconds would be the best delay for this patient. That's test bolus. That's when you're given the contrast, doing a bunch of scans, and then figuring out your timing, and then setting your time, and then doing the scan. Or you can do bolus triggering, where the contrast itself is used. So this is the one where we put the ROI on, and then we set like a threshold, and then we wait for this to go over the line, and then we start the scan. Is that what you guys are more familiar with? Okay, so this is where we, now the problem with this is patient could breathe funny, and you know, then your ROI is screwed up, and then you might be late or early or whatever, but it tends to work fairly well, I think. So you're going to put your ROI on the pulmonary artery. You're going to set a threshold. This is about, I guess, 125, and we're going to say when this hits this line, we're going to start the scan. And usually it works pretty well. I just threw this in here again just to kind of show you the route of the contrast, how it comes up in subclavian, brachiocephalic, and goes through. You can look at that later. A little bit about pediatric contrast. Contrast is administered to pediatric patients for probably all the same indications as for adults. Typical pediatric dose of IV contrast media is about 2 mLs per kilogram of body weight, or about 1 cc per pound, up to about 50 pounds. And then if your kid is over 50 pounds, you might have to adjust a little bit from there. That's pretty typical for pediatric doses. Injecting a pediatric patient. I went to a conference before where a guy from a big pediatric hospital gave a talk, and this is just what he said. I'm not saying this is correct, because some places may not, but if a patient is under 50 pounds, they typically do not use the power injector for those patients. If a patient is over 50 pounds, then it's safe to power inject. Now, I don't know what they do at university or shock trauma. Maybe that's a question I can ask Catherine. I should probably ask her that. That maybe they do. Maybe pediatric cancer patients get power injected. I don't know. But that was just like a rule of thumb that he told us at a conference, and it always kind of stuck with me. You guys probably have not had a lot of experience at your facilities. The outpatient centers probably never get pediatric patients. I don't know about Mercy. Do they have a big pediatric now? So, I don't know. That's just my rule of thumb from what I heard years ago, and it's kind of always stuck with me. But I'll have to ask Catherine what they do at University of Maryland. This is just talking a little bit about oral contrast for patients, about pediatric patients, how much oral contrast you should give a pediatric patient. 0 to 6 months, 40 to 60 cc's, 6 to 18 months, 120 to 160, and so on. You never want to use gastrografin in kids because it has increased osmolality and kind of pulls the fluid from the bowel, and it can cause like an electrolyte imbalance. So on pediatric patients, you don't want to use gastrografin. A little bit about consent. I think I talked about this in one of the lectures or something you guys read, but there's simple consent and there's informed consent. Because of the documented low incidence of adverse events, intravenous injection of contrast may be exempt from the need for informed consent. So some places, I think Franklin does this, they don't even have patients sign for contrast anymore. So when a patient's admitted to the hospital and they sign saying, I give you permission to do what's needed to be done, it's kind of implied that if they need contrast, that they don't have to sign a form anymore. Advance still has patients sign. Does Mercy have patients sign? Good, Sam?
It's still silent, but that one particular patient, the doctor consented for it.
Yeah, when they're like, unconscious or can't sign for themselves. So, that was a new thing for Franklin. They just started doing that maybe, I don't know, 3, 4, 5 years ago. You used to have every patient sign, but now it's kind of just implied that the patient gives consent. But it still is our responsibility to tell the patient of all the risks. And if you look at the CT clinical performance standards, if you see down here, it's our responsibility to fully explain the exam to the patient so that they fully understand its risks, its benefits, the alternatives, the follow-up. We need to provide accurate explanations and instructions. So it's still our responsibility to kind of go over everything with the patient, take a full medical, clinical allergy history, still explain all the risks about the contrast to them. Just some places are not having the patient physically sign a form anymore. Metformin, I think we talked about this a little bit last class. Everybody understand about metformin, how it, metformin, there's a risk of patients taking metformin that they can develop lactic acidosis, and if patients have kidney issues, we have to be more careful with patients that take metformin. We have to figure out what category they're in. If they're a category 1, we don't really have to do anything with them. They just can get contrast and continue taking their metformin as normal. If they fall into category 2, these are patients that have some kind of acute kidney injury or chronic kidney disease. It's suggested that they discontinue their medication at the time of the procedure and withhold it for 48 hours, and then before they start taking it again, they should have a repeat creatinine or GFR drawn or something to make sure that their kidney function is normal and that the contrast hasn't affected it. I know some places, I don't know, does Advance still do this, have every patient take in metformin, sign a sheet? Do you guys know? They don't have that anymore? Okay.
I know when the call center calls them, they ask if you're taking any metformin or stuff, and I think the call center is like responsible for telling them you to withhold it for 48 hours or something like that.
The call center's crap.
Yeah, I know.
Well, just so you guys know, nobody can tell a patient to stop taking their medicine except a physician. Like, you couldn't tell a patient, don't take your metformin for 2 days. I mean, that's way out of our scope of practice. So we never want to tell a patient stop taking their medicine. That has to come from their physician, and a call center should not be telling patients to not take their medicine. That's really bad. Yeah. So anyway, that's about metformin. Now, pre-treatment for patients that have had a prior allergy. So Josh said that his patient only got Benadryl, but typically the pre-medication package is prednisone, and then the prednisone is taken 12 hours and 2 hours before the procedure, and then typically in between there, they'll also give the patient Benadryl, and then they'll give the patient Benadryl before you start the scan. Just remember, steroids that are given less than 6 hours ahead of time, they're not going to benefit the patient. It takes that long for the half-life and everything. So just remember that steroids need to be given at least 6 hours ahead of time for them to have any kind of benefit for the patient. A little bit about contrast reactions, and I'm not going to spend a lot of time on this because I think I gave you guys all this in the online lecture, but there's 2 different kinds of reactions that patients can have. They can have either chemotoxic, where these reactions are specifically related to the contrast pharmacologic properties, and that could be how thick it is, the osmolality of it, the concentration of it. And then there's those idiosyncratic reactions where they're caused by anything other than something in the contrast the patient had an allergy to. Chemotoxic reactions to contrast are variable, and the underlying causes are really not known. Contrast can cause patients to have CIN, which is contrast-induced nephropathy. It can affect their thyroid. It can cause pulmonary effects, where maybe it can that fluid shift can cause like a patient to go into congestive heart failure or something like that. Those idiosyncratic reactions kind of fall into 3 categories: mild, moderate, or severe. Usually mild, we just watch them. We don't really have to do anything. Some radiologists might say give them 100 milligrams of Benadryl and have them sit for a few minutes and, half an hour or so before we let them leave. Moderate, it's not immediately life-threatening, but it could progress, so, we definitely need to watch them. And severe is when it's life-threatening. That would be like anaphylactic or throat swelling or trouble breathing. The pharmacology this week, I think it was in a soft chalk form, so it's not as bad to read as my old lecture was. But you guys should be familiar with the drugs that are in the crash cart and what they're needed for. Not everything, because we're not physicians, but I expect you guys to know what lidocaine is for, what atropine is for, what epinephrine is for, just so that the main ones, so that you have a little bit of knowledge of them. These are all the things that are in a crash cart, by the way. And you should, each of them are on a different, have you guys ever looked inside the crash cart? Yeah, if you ever have a chance, just look in there. Everything's on the top. It usually tells you what shelf everything, what drawers everything's in. But you should, be familiar with these. It's everything that's in there. And I just added on to the end of this just some basic treatments for contrast reactions. Like a patient that has nausea and vomiting, like I said, it could probably just be from side effect from the contrast, usually self-limited. We usually don't have to do anything. Hives, usually we'll give the patient 25 to 50, maybe 100 milligrams of Benadryl. Hypotension, talking a little bit more severe reaction here. Might need to elevate the legs, hang a bag of fluid, hook it up to their line, open it wide open to get fluids in there quick. Bronchospasm, that's always epinephrine. The pens are in the crash cart. Have you guys ever seen those? The self-injecting pens. Usually, radiologists will put it in the thigh. Sometimes you'll see them put it in the arm. I've seen both. But basically, just take the top off, just go like that, and the needle comes out and it injects right away. And those patients who get epinephrine have to go to the hospital. They can't go home after that. They have to go straight to the hospital. Like EpiPens, like people that, carry around. But I don't know if the epinephrine in those on ours crash cart is like different from just a patient that carries it around that like has a bee sting injury. I don't know what the concentration is on those, but they're used the same way. They're just injecting. Just be careful to inject yourself. I saw somebody do that and she was playing around with it and it went off and went in her finger. So just be careful with those. Let's see. Anaphylactic, that's, again, epinephrine. You need to hang a bag of fluid. Usually they'll give IV Benadryl. That's a little more severe reaction. Seizures, I've never seen anybody have a seizure from contrast, but I guess it could happen. So those patients need, obviously protect their airway, make sure they're able to breathe. Pheochromocytoma, we don't really see those anymore with non-ionic contrast. I don't know why this is on the reaction page, but for pregnancy, usually we recommend moms that are breastfeeding that they pump and dump. That's just the recommendation from the ACR. Pre-treatment protocols, this is just, if we're going to pre-med somebody, it's usually Benadryl, prednisone. That's it. All right, who has questions? Anybody? Because I overloaded you with a lot of information tonight. Any questions about anything? Yes. Oh, that's an easy question. Yes, I do want your dosimeter. Yes, I do want your dosimeters. So we covered a lot tonight. Let me just make sure. That's why I always like to have my notes. I get off on a tangent and then I forget to tell you guys stuff. You have a quiz this week. How'd everybody make out with the quizzes last week, okay? So from here on out, you'll probably have a quiz every week. Some weeks, maybe not. I think Catherine has one week where she doesn't give you a quiz. So, I'm gonna post this recording so everybody can review it. Hope I didn't sound too much like a ding dong. Flow rates, pay more attention to them when you're clinical. Make sure that patients are getting the proper dose of contrast that they're supposed to be getting. Again, with the injector, pay attention when they're loading it, about that tilt. You guys were like shocked by that. But text at the site, they might not know that those Mallinckrodts blink when they're at the right angle. So you want to make sure that you do that at the right angle so all that residual air goes to the back of the syringe because we don't want to accidentally inject anybody with air. Pay attention to the concentration of contrast that they're using. Maybe ask questions like, why did you pick that concentration? Why didn't you do this? Why don't you use the VisiPig? How come you don't use those diffusics? Just gingerly put them in the conversation just to find those things out. What else? Any other questions about anything? Everybody feel okay with contrast now? I know it's a lot. Pay attention to when you're doing those multi-phase imaging exams, like look at the delay, look how much contrast they're putting in. Pay attention to what, the aorta and the IVC looks like in comparison to each other, then you know if you have a good study or not. Anything else? Anybody else? Questions, comments? Okay, so I'm definitely going to be working on the clinical schedule to get that done for you guys. So I hopefully, what's this, week 4, so next week's week 5. So hopefully I'll have it done by next week so I can send it to all of you for review. Just review it, make sure that I have your days correct. Also, if there's any preclinical stuff that you need to do, make sure that you check on Blackboard. I know Mercy, you got to take us stuff with you to go. I know St. Joe, there's things that need to be done if somebody goes to St. Joe. So just check those things, and I'll try to get that to you guys next week sometime. So, all right, well, if nobody has any other questions, that's it.